Good afternoon, everyone. Thank you for joining us for our Sync series webinar today on preparing for 340B policy changes. My name is Shayna Lenove. I lead our fiscal health professional services here at Health HIV, and I'm very excited to welcome you to our final Sync series webinar before our Synchronicity 2018 conference in a couple of weeks here in Washington, D.C. Today's webinar will discuss proposed legislative changes to the 340B drug pricing program and some strategies for HIV and STD prevention programs to sustain income and services if these changes roll out. Before we dive in, I just want to cover a couple of housekeeping items. This webinar is being recorded and it will be available following the live session today on the resources page of Health HIV's website. And if you have any questions during the webinar, please just write them into the Q&A box in the corner of your screen, and we'll try to get to those at the end of the webinar today. I know we have a big group on, so we'll hopefully get to everything that we can. If you are dialing in, the number is available here on the screen. You can use either computer or phone audio to access the webinar. And as I mentioned, this webinar is part of our Sync series leading up to our national conference this month. And following today's webinar, if you're interested in more training on maximizing 340B income and overall fiscal management, Sync 2018 is also hosting a national fiscal health training, which will discuss some of these themes and how they relate to HIV care and prevention programs. So our speaker today is Rita Baskett. Rita has extensive experience in implementing 340B programs and helping organizations manage their pharmacy relations and maintain compliance with federal standards. I'll let Rita introduce herself a little bit more after we just go through quickly some of these learning objectives for today's webinar. Our goals for today are to identify some of these proposed changes to the 340B drug pricing program, some of those legislative changes. We'll also describe what the impact of those potential changes are on HIV and STD programs, and that will include some discussion of pharmacy relations, financial sustainability and client enrollment, and we'll also discuss some strategies for HIV and STD prevention programs to respond to these changes and adapt their programs. So Rita, I will at this point turn it over to you and we can dive right in.
Great. Thank you very much, Shayna. And hello, good afternoon, or good day to everyone on the line. I'm Rita Baskett. I am Chief Executive Officer and Operating Officer of Integrated Pharmacy Services. We are a 340B firm that assists covered entities within the 340B program all around. So I appreciate the chance to speak to you all today to discuss some of the legislative initiatives and changes and policies that's going on in the 340B marketplace. As you may be aware or may not be aware, there's plenty going on the Hill today. So what I'm going to do is cover as much as I can and hopefully leave enough time for some Q&A at the end. So I just wanted to go over the hierarchy of the 340B program, where it sits. So 340B, along with your grantee status, sits within HRSA, which is Health Resources and Services Administration. And HRSA is a division of the Department of Health and Human Services. They report to the Congressional Committee, House Energy and Commerce. So when you hear a lot about what's going on within the program, most of the hearings were done within the House Energy and Commerce Committee, which we'll discuss further in detail. They govern the 340B program, drug pricing program, which is officially called, and that's through the Office of Pharmacy Affairs. So again, we are all under HRSA at some form of fashion within the 340B program. So to start off, what was the biggest thing that occurred within the 340B program was a CMS Payment Reduction, which is from the Department of Health and Human Services. And so that was a payment reduction that was specifically done to hospitals that participate in the 340B program. So if you were a disproportionate share hospital or a rural referral center or an urban sole community hospital, you got hit by this payment reduction because these hospitals are paid on what is called the Outpatient Prospective Payment System, OPPS. Does not affect the grantees directly in this per se, but this was one of the biggest hits to 340B participating entities. And these were drugs that were billed on what we call Schedule K. And these are a lot of infusion drugs, a lot of chemotherapy drugs, high-priced drugs, and different drugs that are paid billable through Medicare Part B. This CMS payment reduction rule went into effect January 1st of 2018. And that payment reduction reduced their reimbursement from CMS for Medicare Part B drugs all the way to ASP, which is average sales price, minus 22.5%. So prior to the payment reduction, these hospital types were receiving ASP plus 6%. And that was for any hospital participating in Medicare Part B being paid through the OPPS system. So this in total is a reduction of about 28.5%. So we'll talk about how that can potentially affect you in the long run because these hospitals are currently receiving that as of January 1st. So to counteract that reduction in payment, because that actual CMS rule went into effect 1/1. It was first introduced in July of 2017. They went through rule and comments, and naturally the hospitals petitioned against that rule, but it still was implemented. So since it was implemented, there was a nice introductory bill called HR 4392. It was introduced in November by Representative McKinley from West Virginia to reverse this CMS payment reduction. So it received 194 co-sponsors to date. Co-sponsors are other members of the House of Representatives. So it received 194 co-sponsors, then it kind of stalled. So currently there's not a lot going on with this bill, but we're hoping at some point in time there will be more heard or more introduced on that bill to help the hospitals relieve them of that payment reduction. So we have another bill that's circulating right now in the House. It's HR 4710. And that bill is called the 340B Protecting Access for the Underserved and Safety Net Entities. It's called the PAWS Act. And basically this bill, which was introduced by Representative Bouchon and Representative Peters, and it's a bipartisan bill that was introduced in December of last year, currently has 4 co-sponsors. Not a lot of traction on that bill yet. But what this bill is hitting is for transparency, and this is what we're hearing day after day in regards to 340B. And what is transparency? Transparency is basically they want to know in this bill, they want to introduce legislation to say what is the drug's price, the acquisition cost, and the charity care that is being offered from these covered entities. They want to know exactly how much are covered entities receiving in savings from 340B. But it does not ask for transparency from the drug manufacturers. That is not included in this bill. But it asks for 340B service charges and costs. They want to know what claims are 340B related to be grouped by a certain payer source. So they want to know if it's a Medicare, if it's Medicaid, if it's a commercial payer, and what are your charges, and what are those costs related to those charges being billed to the patients. So this is for our hospitals. It's a bill, again, that's introduced to target 340B hospitals for transparency. But again, this does trickle down to the grantees as well. And where this hurts is actually limiting hospitals and child sites from enrolling into the 340B program for 2 years. So if this bill gets final approval at some point from the time the bill is enacted, they want to stop all 340B enrollment for hospitals and in certain child sites for 2 years. So what this may do to grantees like yourselves, this may actually steer services from facilities that could have qualified for 340B, that could have used savings for 340B to offer more charitable services. Due to that lack of enrollment, it may steer patients underinsured and the uninsured your way instead of to the larger, to the medical institutions, the hospitals that need to participate in the program and that are eligible. And that, in turn, causes a reduction in charity care by these health systems. They're not able to have the 340B savings to actually give the charitable service to the underinsured, the uninsured. So that bill is quite loaded on how it affects the program. And so the Senate introduced something very similar called the HELP Act, helping ensure low-income patients have access to care and treatment. That bill was introduced by Senator Cassidy, and this is a Senate bill, Senate 2312. So that bill came out in January, and that bill states the same type of verbiage as the House bill. It wants transparency of 340B savings in hospitals, and it wants to also pause enrollment of eligible hospitals and child sites for 2 years as well. So we call this the Senate version. As typical bills are introduced, they introduced in the House, they're introduced in the Senate, and then someone kind of duplicates it in the corresponding House or Senate. So currently that bill has no co-sponsors yet, but there's a lot of talk circulating about this bill because, again, it hits on transparency. And that's going to be kind of the word for the day, transparency. Also, what we have moving is since we have a new administration in office that has been in office for now a little over a year, we have a new budget for fiscal year 2019. And in this budget is 3 implications to the 340B program. So what the budget currently is asked in the bill is for $26 million for 340B drug pricing program. Of that, $10 million is a discretionary budget authority, and that $10 million is the budget that is going to be allocated regardless. But $16 million of that money is going to be introduced as what they call new user fees. And so this new user fee, which is not really new, is being reintroduced again. And what it is a fee for drugs that are purchased by all covered entities. And so they're thinking and they're anticipating $16 million will come from that user fee. And so as I say in this slide, that's a user fee again. This was proposed by HRSA back in 2011. And again, it's a fee for every drug you buy. It's almost like a tax. So you buy 340B drugs from your wholesaler, there's a tax on the 340B sales. It was never implemented when it was first introduced back in 2011. It passed the Senate Appropriations Committee, but it also has to pass the House Appropriations Committee for it to become an actual budgetary item. So what they were asking for previously, and they're asking for again, is this 0.1% of total 340B purchases. That's the user fee. The issue with the user fee, which has been argued and why it probably wasn't implemented in 2011 and probably may not be implemented again, but we don't know. Again, it's proposed in the budget for 2019. They argued, who is going to collect the fee? Will it be your wholesaler collecting that fee, or will the health systems or covered entities like yourself have to pay that directly to someone or organization. Who's going to collect that fee? Again, and who's going to monitor the oversight of this fee as well? So that's the big issue with the user fee. It's not something new. Again, it was introduced in 2011, but for it to show up in this year's budget, and especially with all the scrutiny of the 340B program that's happening right now, it may gain some traction to fund HRSA 340B oversight. Another thing that occurred within the program happened this year, early this year in January, was a published report from the House Energy and Commerce. So again, I spoke of the hierarchy of HRSA, and the reason I spoke about that is because I wanted to explain who in Congress, which committee oversees the 340B program from HRSA. And again, it's House Energy and Commerce. So they had a few hearings, which I'll go into more detail about, but from the hearings, this report surfaced. And the report surfaced January 10th, and you're welcome. There's a link in the slide deck that takes you directly to the report itself. But basically, my Cliff Notes version of the report that I provided for you to explain is what they saw is necessary for the governing of the 340B program. And one of the key takeaways from that report from the House Energy and Commerce said that HRSA lacks sufficient regulatory authority to adequately oversee the program and clarify program requirements. And so in 2014, a federal court ruled that HRSA's regulatory authority is limited to 3 specific areas. So this is why we don't see a lot of movement on the 340B program by HRSA, because all HRSA can issue currently is guidance outside of these 3 specific areas. One specific regulatory authority area they have is for establishing and implementing a binding administrative dispute resolution process. And so that is a resolution for certain disputes relating to compliance within the 340B program. They have not implemented any rule to that date in regards to the ADR. So we haven't seen anything, any regulatory rule from HRSA. Number 2, they do have the imposition they have the authority to impose civil monetary penalties against manufacturers that knowingly and intentionally overcharge an entity for a 340B price drug. So basically, if a manufacturer knowingly and intentionally hikes their drug price on 340B, HRSA does have the regulatory authority to penalize the drug manufacturer, but they have yet to impose and to make that rule final yet. It keeps getting pushed back. We saw the last wording from this current administration that it was pushed back to August. So we still have yet to see them roll out the penalty to the manufacturers. And so number 3, the only other regulatory authority that HRSA has is to define the standards and methodology for calculating 340B ceiling prices. So today, ceiling prices to calculate 340B is basically unknown to the users of the program, like yourself. And so HRSA was supposed to actually create a secure website that has the true 340B price for every covered entity to be able to log in. So if you've noticed over the last year or so, HRSA has updated their website. If you were to look and search for covered entities, child sites, contract pharmacy information, they now have to have a login, a specific login, your entity information in order to go into OPA's, they call it OPAIS, the information system, and that was created so that they can release this pricing clearinghouse. We called it a clearinghouse. And as of to date, the clearinghouse still has not been released to you all as covered entities. So unfortunately, these are 3 things that HRSA has regulatory authority to do, and as of date, they have not. So I just wanted to point out why things slowly move through HRSA, because they only have regulatory authority in these 3 very specific areas. So the House Energy and Commerce did have two recent hearings last year. They had one in July of 2017 and October of 2017. This is how they came up with this report. And in those hearings, and they are on the House Energy and Commerce website, if you're ever interested in listening to those hearings, they're also available, I believe, on YouTube. They're about 4 hours each, so you'll need a lot of time to sit and listen to those. But basically, those hearings were about the program, and they had different representatives. They had hospital representatives. They had FQHC. They had an HIV/AIDS grantee present to talk about the 340B program. And then from those hearings, Congress sent out letters to specific covered entities asking for very specific information about 340B and their charity care. So they asked the hospital, how do you calculate the savings? What is your savings? What was your 340B spend? What was your charitable care that you gave out in said years? So it was a lot of information in these letters. Again, these letters are public record, so you are privy to go to the House Energy and Commerce and see which covered entities they actually sent those letters to. A few are very large academic 340B covered entity hospitals. I believe there was also a community health center, but this is letters that went out from the congressional members asking for this information. And so, again, the key takeaways from that report was that Congress said, okay, we see HRSA's limited authority. We think that HRSA needs more regulatory authority to properly regulate and administer the 340B program. They feel that HRSA should go ahead and finalize the regulations that they currently do have authority for, the three that we spoke about, and that Congress should give HRSA more resources and staff for more rigorous oversight of the 340B program. So that oversight, more resources, that means basically more auditing. They also want to expand the scope of the audits. They feel that there was, on average, the congressional members spoke of, that there were 87% of the audits had findings, and they thought that was extremely high. Findings could be anywhere from duplicate discount to diversion, drug diversion, and that's drug pricing diversion, and even errors on OPA's registration and website. So even that's considered an error. And so when they looked at all of those audit findings, out of all the audits done by HRSA, they came up with 87% of them had an issue. So they wanted the scope of the audits expanded further by HRSA. Also, they require one of the other report keys were that they wanted covered entities and manufacturers to be audited at the same rate. Currently, there's a disproportionate number of covered entities to manufacturers that's being audited. So they want to see them audited at about the same rate. And lastly, they require certain covered entities to conduct independent audits of program compliance, including of any contract pharmacy. So as you can see, contract pharmacy is going to be a very key hot topic, and I'm going to talk more about that because that's truly implications that may affect your status within 340B, is the contract pharmacy piece. So they want more independent audits done to make sure that this program is in complete compliance within the current HRSA guidelines. Oh, sorry about that. Give me one moment. It looks like my mouse is not bringing up my current PowerPoint slide here. Okay, here we go. Apologize for a moment. Somehow it looks like it's duplicating my slide here.
Rita, this is Shayna. If you'd like me to skip to a slide, you can let me know and I can try it for you.
If you can go ahead and skip the slide, because it looks like I'm getting a repeated slide deck here over and over. Even though it says live, I'm not getting the current slide. Okay, great. Thank you so much, Shane. I think we were at the current slide. I think you were on that talked about the we just talked about the hearings that occurred within the House, Energy and Commerce. So then I wanted to talk about the Senate committee hearing that occurred just this past March. So the Senate Help Committee, which is the Health, Education, Labor, and Pensions Committee, had a hearing on 340B. This was the first ever Senate hearing. So as you know, this is really picking up steam, the 340B program, as far as the congressional oversight of the program. And so the title of their committee hearing meeting was called Perspectives on the 340B Drug Pricing Program. And again, there's a link at the bottom of the slide deck that you can go to if you want to go see the live recorded hearing from March. The witnesses there were the Americans Essential Hospitals, Pharma, they had an executive from Pharma Industry, an FQHC from South Carolina, and ASHP, a pharmacist from the Hospital Pharmacy Organization. And so the Senate panel spoke about benefits of the 340B program to each of their states, their respective states, and how it helped their hospitals. But what they did talk firmly about was transparency. But they spoke about transparency from both the covered entities and from pharma as far as drug pricing. Because as you know, the clearinghouse is not available for us to know what the true drug price is for 340B. We just have to go by what our wholesalers load. And if there's a pricing discrepancy, which sometimes do occur, you notice there's a check that gets funneled back through Apexis, which is the prime vendor program, back to the covered entities if there's a pricing discrepancy. So they grilled both sides, saying we need transparency from the hospitals to know what the savings are, and from the covered entities to know what the savings are, and what they're doing with that, what the income that's potentially generated, and also what true pricing of the drugs are. And they vowed to hold another hearing, and they wanted HRSA to be present this time to testify. So a lot more with that coming. I want to talk a little bit about the GAO report because this is something that's up and coming very soon. We don't have a release date on when this is coming out, but Congress asked the Government Accountability Office to publish another report. And so there was a report published first by them called Update on Agencies' Efforts to Improve the 340B Program Oversight. That's the old report that was published back in July of 2017. But now Congress asked them to publish a new report talking about contract pharmacies. So what the old report that came out in July only touched on a previous report back in September of 2011, and it went over basically their recommendations, which were for auditing, which, 340B auditing started from HRSA back in 2012. That was the first year they started to conduct audits and oversight of the program. So now Congress went back to the GAO and said, okay, since you did a report and you did follow-up, now we want you to do an in-depth report on contract pharmacy relationships. And what they asked the report to cover, this is what Congress asked, for the GAO to look at which covered entities are using contract pharmacies, what are the financial arrangements between the covered entities and these retail pharmacies, what is the discount on these drugs, and how are those drugs passed on and the pricing passed on to low-income uninsured patients, and how covered entities and HRSA ensure compliance within the 340B program requirements of contract pharmacies. So this is what the upcoming report is going to cover. And this is one of the biggest things I think that is going to shake the 340B community and world, because we are in a we've been siloed pretty much with contract pharmacies. There has been no legislative rules that came out to say anything since March of 2010. So prior to March of 2010, you were able to have one contract pharmacy, and if you wanted further, you had to submit a alternative method demonstration project. This is just a little history. So once you submitted that, you were able to then get another contracted pharmacy, and that was basically granted by HRSA officials. But in March of 2010, the Federal Register published that you can go from one to many contract pharmacies. And after that, nothing else has been released about contract pharmacies. And as you know, this is one of the biggest areas of revenue that most of you guys are participating as grantees receive through 340B. You receive savings for anything you give naturally administrating to a patient, but if you have any patients that need to receive medications through a contract pharmacy, you're reaping benefits of that revenue. So how does this all affect you? We'll talk a little bit more about that. So one of the key things is transparency, and that's something that, again, you're going to keep hearing this over and over again, and that's basically revealing your 340B actual acquisition price. And when you do that, naturally, we're kind of opening Pandora's box. By revealing that price, now you're opening the door for commercial payers, self-pay, and even your managed care, Medicaid managed care organizations as well. So commercial payers are now already fighting with manufacturers to get their rebates for drugs that they dispense, but the manufacturers are saying, we don't know if that was a 340B drug given to that patient or not. So the commercial payers are pretty much, I would say, stuck in the middle trying to figure out how do we capture, if we can't capture our rebates, how do we get our money? So the entity, you guys, are using the 340B price in a contracted pharmacy relationship with commercial payers, but the commercial payers don't know if that claim is 340B or not. So that's a huge issue that I could see coming from and through that GAO report as well. And so with that, there may be some identifiers coming through that may with the commercial payers so that they can identify what 340B claims are being adjudicated. And once they identify those, there may be some potential reduction of reimbursement. Some commercial payers have tried this in the past with the GAO report coming out and probably showing how big contract pharmacy has grown over the years. This is something we may see coming in the future. So what are we going to do about this? We'll talk a little bit more what we can do. So also how this affects you with this report, all these reports coming from the congressional committee hearings and the reports that are being created by the GAO that came from the House Energy and Commerce Committee is that oversight. Oversight is one of the biggest issues that they want managed by HRSA. So they want auditing to be increased. That's definitely something we're going to see happen. Every year since auditing has started in 2012, HRSA has increased the number of audits. So every year, I think this past year, their target was 300 audits. Next year, probably 400. So they're trying to increase, once they can get increased revenue, to do more audits. This is something that we definitely would see happening more and more to covered entities, all covered entity types. So one of the things we may also see is independent external audits becoming mandatory by HRSA. So currently it's a recommendation from HRSA, but as oversight of the program, if they continue to see an 87% failure rate, they're going to mandate some form of independent auditing. So you would have to have an independent auditor look at your program, and this way you could stay in compliance with the program. One of the key changes to the auditing we noticed on HRSA's website, they did add some extra, and this is within their regulatory guidance that they could do is that they can remove you from a 340B program if you have repeat violations. So if you're audited the first time, you have some errors, they ask you to submit a corrective action plan. They're now saying, because they're now going back and repeating audits that they've done from 2012. So if you got audited in the past, don't think you got audited once and it's over. HRSA can come back and audit you again, especially if there's findings. So with the findings, they're saying if we do a second audit or a third audit and those same violations are being repeated, so if you have issues with diversion, drug pricing diversion, giving drugs to a non-eligible 340B, or you have an issue with duplicate discount, and they're seeing these repeated in the second or third audit, they do have the right then to remove you from participating in the 340B program. So that was the newest thing in the last 6 months that HRSA has added to their website about program integrity and audits. So you're more than welcome to look at their HRSA's website and look at the link on program integrity under the 340B program where they talk about these violations and how they can actually take you out of the program altogether. And so I know I talked a little bit about it already. It's the contract pharmacy piece with the implications for that upcoming GAO report on contract pharmacy. We don't know when that's going to come out, but when it comes out, I'm sure it's going to be some rolling implications from that. So what we need to do as covered entities is to prepare ourselves in preserving the program and preserving our contract pharmacy relationships. One of the things you may want to do is start looking at the number of contract pharmacies that you have. If some of them are not profitable, remove them. If they're not, remove them off of HRSA's website. What we don't need is several pharmacies listed because there are some very aggressive retailers out there that I have you sign with every pharmacy in the neighborhood, maybe 50 of them, you know. They just want you to sign in their agreement so that if they capture one 340B prescription, you can reap the savings or the revenue from it. But that has lasting implications on the program because, like I said, the program has doubled in the last years because of the increase of contract pharmacy relationships. In some of them, I know by doing audits, you will see that some of those facilities are not even participating contract pharmacies. They're just listed on the website. But for optics, they're there. They're counting those number of pharmacies. So if you're not using them, please remove them. A second thing, like I said, is looking at which ones are profitable and which ones are not. If you need to start looking at those financial pieces too. So if you go back and you're looking at, okay, this pharmacy, we're breaking even, we're never making money, or we're never receiving revenue in a decent type of, losing my words here, margin of money from that stream, from that revenue stream, then maybe you need to terminate that relationship as well. So those are some of the, with knowing that these implications are going to come from the report, they're going to probably make suggestions for hospitals, covered entities, grantees to reduce the number of contract pharmacies. I can foresee that, so I would like us to get in front of some of that just for optics. And also, there may be some forced transparency because that is the word of the day, where they may have us, covered entities, show what your savings are, what your revenue is from commercial payers, and that can then in turn lead to payment reductions from those commercial payers. So as I talked ahead a little bit, I did ask for you to be able to keep your program and to keep 340B alive, especially in the contract pharmacy realm, is reducing the number of the unused contract pharmacies and, again, discontinue use of those non-profitable contract pharmacy relationships. Also, what you can do is conduct annual independent audits to ensure compliance. You want to make sure that when you do get audited, you don't have an unfavorable report, and it will help reduce those numbers on OPA's program integrity side of saying this is the number of facilities that have failed audits. So those are different ways that we see that you can actually help maintain, help keep the program around, and also keep your revenue stream in good shape with 340B. There's been some industry changes too. I know we talked about policy, we talked about legislative things on the Hill reports, but there's been some industry changes too. A lot of mergers have occurred, which are also tapping into revenue streams. So you may want to look at some of your contracts with your, what we call third-party administrators. Those are the companies that are your, I call them the middleman, so to speak, because they take your data and they take the contract pharmacy's data, and they basically tell you what your margins are. But there's been an increase in mergers. So we have pharmacies merging with TPAs like the Rite Aid Capture mergers. CVS just went into a merger with WellPartner. Actually, not merger, they bought WellPartner. So now they own a TPA along with the pharmacy. So now they are increasing what they're asking for in dispensing fees. I do know one of the TPAs, and this is public record, in Florida, Century, had filed an antitrust complaint against CVS. So there's more to come on that. Again, that's public record. You can go to the Florida state to see where that lawsuit was filed, because they're not happy with that merger, because, again, they may be charging less fees than WellPartner, and now you're being forced to use WellPartner if you got those letters. And I believe they're changing all of their clients over to December this year. And so that may increase your oversight to manage more than one third-party administrator. So you'll have multiple if you're dealing with CVS. And we've also seen an uptick in dispensing fees. So with the uptick in dispensing fees, it seems like every year the contracts within the contract pharmacies have been going up. So you may, if you don't already have a contract, you may want to start looking at brand-only contracts, which the generics typically, not always, are losers, and that may be cutting into your revenue stream. So you might want to go back, look at your contracts and say, okay, it looks like I'm losing money here on the generics that we're processing in a contract relationship, and you may then be able to change over to a brand only. So you can do that financial analysis. I would suggest you do that analysis as well to look at and see if a brand only contract may be favorable for you. So with that, I talked a whole lot, which I do, and I do talk fast. So we're going to stop and open up the lines in the Q&A boxes for discussion and questions. And I'm going to turn this back over to Shana.
Thank you, Rita. That was a lot of great information. I know there's a lot to think about when we are looking at these potential changes. So it's great to have some of that overview and think about what those implications might be for especially these HIV and STD prevention programs that we've been working with. I want to give people a couple more seconds to write some questions into the Q&A box if there are any more that are coming in. We've gotten a few great questions, but I'll just give everyone a couple of minutes. And I just want to point out in the meantime that the slides will be available after this webinar. I know several people have asked for them, and there are some links in those slides that will be important to reference. So those slides will be available afterwards, and we can send them out to everyone who participated. The recording will also be available on Help HIV's website following this session, so that is all available. I just want to highlight one other thing. I know, Rita, you've been talking a lot about what some strategies are for programs to stay compliant and maintain program integrity, and that includes preparing for an audit, and those are all really key components of enrolling and participating in a 340B program and kind of looking out for those changes. And it sounds like a lot of this really relates to the theme of sustainability as well, just knowing that some of these changes could be coming along and impacting HIV and STD programs. So I know the 340B for a lot of covered entities is a way to expand service delivery, and that's not always easy to manage that income that comes in. So there are other trainings that we have available for these covered entities on fiscal management of these types of programs. And as I mentioned earlier in the session, we do have a national training coming up in a couple of weeks that will cover some of these topics. So I'll include some information afterwards on how to get access to that training as well. But I'll come back to some questions now, as I've seen several more have come in. Rita, I'm just going to start with I think hopefully a simple one. Somebody had asked, do you recommend a certain number of contract pharmacies? I assume this depends, but I'll let you answer that one.
Right, and that really depends. Again, I will always tell anyone, before you start any contract pharmacy relationships, look at the feasibility, financial feasibility. If you don't have enough sites to render the prescription numbers, limit your contract pharmacies to specific geographical areas that may help your clientele. So that's the key, is getting the meds to your patients. And if you have one pharmacy in your neighborhood, fine. If you have 20 in your neighborhood, fine. But look at those 20 and see which is feasible, because maybe a subset only uses 5 of those 20. So that's what you want to target, is which ones are actually financially feasible. If not, do not list them on OPA's website for keeping this program sustainability and optics.
Great, thank you, Rita. We've also gotten a couple other questions about, I know there are lots of types of entities that can participate in the 340B program across federal recipients and hospital programs. We've gotten a couple questions on whether these points that you've made, whether there's anything additional that might apply specifically to an FQHC, a Federal Qualified Health Center, or a health department. Is there anything that you know of that would be especially important for those types of entities to know about that wasn't already covered?
Right. Currently, there is not any bills on the House or Senate floor that targets the grantees directly. What do target you directly, which we spoke about, is the budget, because that budget is what governs HRSA and finances HRSA's ability to govern the 340B program. And that's those user fees. And that would apply to every participating entity. So from FQHCs to ADAP grantees to TB, STDs, family planning, to large disproportionate share hospitals, that user fee definitely is what can target you. And then also the GAO's contract pharmacy, because all covered entity types can have a contract pharmacy relationship. So that report, which we're all sitting on pins and needles waiting for it to come out, will definitely have repercussions to every covered entity type. But nothing else is on the House floor or Senate floor directly to affect 340B for the grantees.
Great. Okay, thank you. I've seen several questions come in about spending 340B income, and I'll just, Rita, you may have something else to say about this, but I can kind of touch on that. I know that several of these have asked about Ryan White programs specifically. There are several additional fiscal monitoring requirements that are pertain specifically to federal grantees like Ryan White programs and STD programs and FQHCs in terms of what those allowable expenses are for that income. And I think that is a sort of a lengthy discussion and maybe outside of the scope of this webinar, but that's also something that Health HIV can provide additional training on in terms of how to stay compliant with those federal awards as well that qualify entities for 340B participation. So for my answer on that one, I'll just say it depends as well. And I would recommend looking more specifically at a notice of grant award or something like that that would list what those allowable expenses are. And we can strategize more about that individually. But and Rita, I'll let you, say anything else on that if you have something. But in the meantime, I'll also go back to another question that we've gotten several times now, which is if a entity has contracted with a commercial pharmacy that has multiple locations or is a national chain, is that considered an individual pharmacy?
So on that question, each individual location is a pharmacy. So it can be a large chain, national chain. I will just call them, you'll hear the commercial, Happy and Healthy Corner or whatever they call themselves on the corner of Happy and Healthy. I'm not going to say their name specifically, but every location that they register is considered a pharmacy location. So it may be 25 in that chain specific. So that's 25 registered covered entities. And so they also count how many child sites. So if you are an entity with several locations and each location has the potential to write a prescription, and each location contracts with 25 of those pharmacies, and you have, let's say, 4 locations, they will consider that 100 registrations because each location is contracted. So that's where they're getting these elevated numbers, but at the same time, each pharmacy is a considered contractual relationship in contract pharmacy. To go back, Shana, to your fiscal question, as far as the grant, I have to actually leave that to you guys. That's what your wheelhouse that you do best as far as explaining how to manage that program income. And like you said, I believe you have some resources that you can direct them to on how to and what they can do as far as their grantee dollars.
Great. Thank you, Rita. And I have seen several other questions about that come in more specifically related to Ryan White. So again, I'll point participants to our training that we're doing in 2 weeks here in Washington, D.C. that really goes more in depth on some strategies for spending income that's generated from 340B programs that's compliant with HRSA HAB's requirements and the fiscal monitoring standards. I know HRSA HAB has more restrictive guidance than other programs do in terms of how programs can be enrolled and what are the allowable expenses that can be applied to those programs. So I will make sure to send out that information following this webinar since it sounds like that's been a pretty popular question. I'm going to end with one more for you, Rita, though. A question that we just got was, will HRSA provide guidance on what they will be looking for when they come to audit a covered entity? And are there best practices that you know of that anyone's using to ensure compliance? I know that's a big question, so you may just be able to summarize it a little bit based on your own experience.
Sure, great. And that's a great question. I didn't want to go into an audit webinar because I wanted to talk about this is more on policy changes. But to go over the HRSA audits, if you go to their website under program integrity, you can kind of get a feel on what they're looking for. And they do not offer an exact template of what they're coming in for, but they look at key areas. Registration, whatever you have registered on OPA's website has to be accurate. So if you're registering a Medicaid number, has to be the right number. Addresses, shipping information, they look at everything that's registered, contact person, authorizing official, those type of things they look for. Diversion. A patient not eligible to receive a 340B price drug. That's the big one, diversion. Third is duplicate discount. Duplicate discount is basically you receiving the 340B price or state Medicaid fee for service. And this, I'll repeat this again, fee for service, because HRSA can only audit for Medicaid fee for service, not Medicaid managed care. Big difference. The guidance came out in 1992, 340B program information. Medicaid managed care did not exist then, so they cannot audit for managed care. They can only audit duplicate discount for Medicaid fee for service. So either you get the rebate, which is the 340B price, or Medicaid gets the rebate. So they audit for duplicate discount. They also look at your policies and procedures. Got to have policies. So they look to see, are you following your policies and procedures? If not, if they find a difference, they will then make suggestions or have you update your policies. But those are your key areas of an audit that HRSA comes in to do for your entity type. They want to make sure that you're following the patient definition and that you're keeping, you're using 340B on your eligible patients, and that you're not receiving or creating a duplicate discount issue with the state that you reside in. So those are your key focal areas on auditing. And when I go into different covered entities, this is the best practices that I pull from there, is to take the recommendation from HRSA, is to have those independent annual audits done, so that this way you know and you can catch anything before HRSA walks into your door. What you do not want is a finding for diversion or duplicate discount, because that creates payback to the manufacturers on those findings. So that's the key. There are the penalty of paying back the manufacturer for the audits, for the issues they find in the audits. And again, if you've been audited in the past, they will come back. So don't think you're in the clear if you've been audited once.
Great. Thank you so much, Rita, for all of that guidance. I think that's been very informative. Sounds like there's a lot to look out for in terms of these changes and how they could potentially impact HIV and STD programs and FQHCs and other programs that are enrolled in 340B or interacting with the program. Again, thank you for all of that overview on this. We've gotten many more questions coming in that I'm sorry we don't have the time for today to answer, but please do reach out with those questions and we can connect you to the answers on those. I've put up a slide here on the training that I've mentioned, since we've gotten several requests for that. More information can be found at the website that you see there, sync2018.org. If you're interested specifically in the fiscal health training that's during this conference, I'll put my own contact information up here. Again, my name is Shana Lenove. I lead our fiscal health services, and I'm leading this training in a couple of weeks, so please reach out to me if you have any questions about content or scheduling for that. And lastly, I will send out to everyone who participated the information that I mentioned about upcoming opportunities for training on this topic, as well as the slides and a link to the evaluation for this webinar. We'd really appreciate if you could fill that out very briefly. And lastly, I just want to thank Rita once again for a very informative session on some of these proposed legislative changes. It sounds like we have a lot to look out for. So thank you again, Rita.
You're very welcome, and thank you everyone for participating and listening in today.